Welcome. My name is Rasha K, and I'm one of the deputy editors at JACC, and it's my absolute pleasure today to be joined by Navin, who's a professor of medicine at Tufts. Navin, thank you so much for sending your work to JACC, and congratulations on having simultaneous publication along with your presentation at ESC. We're here to talk about your work as the director of the Cardiogenic Shock Working Group and your recent publication with JACC about SCAI severity grade and exactly what that means for our patients and how that changes over the time period that they're in hospital. So Navin, please, could you tell us a little bit about your publication and your main findings?
Yeah, great. Thanks so much, Rasha, for the invitation and for the opportunity to highlight our work. To start, the Cardiogenic Shock Working Group is an academic research consortium of about 40 hospitals in the United States and around the world. It is a registry that we collect regarding patients in cardiogenic shock. It includes patients who are treated with drug therapy as well as device therapy. This work in particular that we were thrilled to have accepted to JACC and also for presentation and co-publication with the ESC meeting was led by Van Quay Ton at Mass General Hospital and also by Song Lee, who's our Director of Data Science at the Shock Working Group. The work is critically important because it addresses an important gap in the space of cardiogenic shock knowledge. The vast majority of papers that are published in cardiogenic shock focus on total hospitalization in total. They look at the end point of in-hospital mortality, or they look at longer-term follow-up, 30 days, 6 months, and 1 year. What we've decided to do is shift the lens a little bit towards the intra-hospital stay itself. And as one of the few registries that collects data throughout hospitalization, we have an opportunity to look at different time intervals as the patient evolves from when shock is diagnosed to 24, 48, 72 hours later and throughout their hospitalization. So this work capitalizes and is basically founded on an original observation from the Shock Working Group that was also published in JACC in 2022, looking at the SCAI stages. So 2 points there. The SCAI stages that the Cardiogenic Shock Working Group implements utilizes a slightly different definition of SCAI B shock. SCAI B, which stands for beginning shock, in the Shock Working Group definition, allows for patients who are normotensive but hypoperfusing, which means they may have an elevated lactate but a normal blood pressure. And those patients we consider in cardiogenic shock, and they fall into the SCAI B category. The 2022 publication found that 90% of those SCAI B patients deteriorate during hospitalization to a worsening condition in cardiogenic shock. What we didn't know is when they deteriorate. When does this occur? Can it occur at any time during hospitalization? And that's how this work, led by Dr. Tone and the team, basically started to look at time intervals. And one of the key observations from this work is that out of 4,400 patients with cardiogenic shock, we found that patients who present with SCAI B cardiogenic shock deteriorate, about 54% of them deteriorate within the first 24 hours of presentation of cardiogenic shock. Similarly, SCAI C patients, about 50% of those patients will also deteriorate, and that deterioration occurs in the first 24 hours. Now, what that tells us is a couple of things. One is that the deterioration occurs early in hospitalization, and after 24 hours, these patients stay in their SCAI stage for a period of time, for a number of days, in fact. So what that started us to realize is that actually the time for assessment and intervention is likely within those first 24 hours. So we've now started to term that 24 hours the golden day, which means we have 24 hours to assess, intervene, and then reassess our patient to try to get them to a more stable condition and ideally to a lower SCAI stage so that they actually are showing signs of improvement. B, for example, going to A, C going to B, etc. So that's really one of the central take-home messages of the paper. What you'll also find in the paper is a deep dive on who are the patients that deteriorate versus the ones who do not deteriorate. We want to better understand those phenotypes. The third thing that we learned is that this also is dependent on whether they present with myocardial infarction or present with heart failure. And then the final point is when we performed our multivariate analysis, once again, we find and confirm that the use of lactate is critically important in terms of detecting what trajectory your patient is going in. And so patients who have an elevated lactate at baseline, higher risk for mortality, and patients who do not normalize their lactate within the first 24 hours, also higher risk of mortality.
Thank you so much, Navin. So maybe you could tell us, I know that this was a big data set and obviously encompassed patients who presented with acute myocardial infarction or heart failure related cardiogenic shock. What did you see in terms of the differences between those two groups and what we learned there?
Yeah, critically important. So what we're learning is that a lot of patients with acute myocardial infarction are getting mechanical support quite early, which I think is good. And in fact, based on the danger shock trial results, we think that sort of is consistent with what is now an emerging theme about early MCS for AMI shock. For heart failure patients, it's a little bit different story. A lot of those patients will receive drug therapy, which is also quite appropriate, and they may get mechanical support at later time points in their hospitalization. And so how that falls into their trajectory still remains to be determined. And I think that's one of the key observations as we go forward is to take a more granular look, one at looking more specifically at shorter time intervals. So actually at ESC, there will also be another publication, another presentation from the Cardiogenic Shock Working Group led by Dr. Elric Zweck. And that will actually magnify the 24-hour period. And we now look at every 6-hour intervals within the 24 hours to figure out, is it really the golden day or is it now down to a matter of hours? And so that'll be an exciting paired presentation at ESC as well, which is not yet published. But I think one of the things for MI versus heart failure is the use of technology such as mechanical support, showing effects with myocardial infarction that are beneficial. And then also in the setting of heart failure, it's really the assessment. The use of a PA catheter early, for example, may lead to better phenotyping of your patient and again allow for tailored drug therapy or trigger the need for mechanical support. But invasive hemodynamic assessment was a big difference between the two arms as well.
Thank you so much, Navin. So obviously what we've also seen here is this is essentially observational data, a very big data set and retrospective, but this is a very hard group of patients to study in an RCT. So what do you think, what does this lead us to next? What would you like to see next from the data and what limitations from this data would you like to build on in the next piece of work?
Yeah, this is really an exciting time for cardiogenic shock science. What we're seeing with this data set, is the unique ability to look at temporal changes over time. We look at significant granularity in terms of hemodynamics, metabolics, as well as looking at various devices that are being used and drugs that are being used as well. So I think there's an opportunity to expand the registry work, continue that. But more importantly, I think what we're seeing now, especially on the heels of the danger trial, is the ability and the opportunity to emulate randomized controlled trials. Can we transport the findings from the danger trial and look at them in these real world data sets? And so we've now partnered with the Harvard Chan School of Public Health, with Bobby Ye from the Smith Center, to really start to look at things like causal inference, look at transportability, and look at the ability to develop more predictive tools that'll aid the clinician at the bedside. So they have, for example, a clinical decision support platform where they can input data based on thousands and thousands of patients from a retrospective registry, but the ones that are designed to emulate those in RCTs. And this opens up the next generation, I think, of what we're going to see for evidence generation, which will start to focus on coupling real-world data with randomized trials, thinking about the concept of platform trials, but more importantly, seeing whether or not we can emulate those findings. And that's where we're headed next with the Cardiogenic Shock Working Group.
Fantastic. So maybe for us as the kind of practicing clinicians next week, what do you think this data mean and how are we going to treat our shock patients? What do you want us to do in that first 24, 48-hour period?
Yeah, critically important. So we think our data supports what is now really becoming the canonical approach to cardiogenic shock. What that means is that we're seeing more evidence supporting the need for early assessment with PA catheter for patients with heart failure, early acquisition of a lactate value for patients with cardiogenic shock to determine risk of mortality. early mechanical support use for patients with myocardial infarction in the first 24 hours who do not stabilize, and importantly, continuing to monitor that patient on an hourly basis within that first 24 hours. Our data essentially shows that if you don't stabilize that patient in the first 24 hours, the likelihood of achieving stability is now reduced. This has implications also for patients who are in community hospitals who are being transferred to tertiary or quaternary care centers for more advanced care. That transfer time now has to be on the order of hours because the whole continuum of 24 hours includes patients who are transferred. So what that means is you can't stay in a hospital and wait around for a day or two before transferring your shock patients. So it highlights the importance of timing element. And I think what we will get to ultimately going from the golden day down to potentially the golden hours is also looking at door to support time and door to assessment time. This is really where the field needs to go. And it's what we're seeing, not just from our data, but also from multiple data sources, multiple registries and RCTs that are supporting this concept.
Thank you so much. This has been fantastic. Thank you, Navin, for sending your work to JACC. Congratulations on the publication and presentation. And thank you for taking the time today to highlight what this means for us as clinicians. So thank you very much.
Great. Thank you as well.